Good afternoon, everyone. Welcome to the post lunch session on combined treatments in aesthetics. And we have a fascinating panel of speakers today. I would like to invite Dr. Madiha Khan, who's going to be speaking on Beyond the Syringe, the Science and Art of Bioremodeling in Skin Aging. So please welcome Dr. Madiha Khan.
Good afternoon, everyone. So, aesthetic medicine has changed dramatically over the last few years. Mic working?
No, no, it's not.
But we hear you.
We can hear it though.
We can hear you.
Loud enough? So, good afternoon again.
Good afternoon.
Aesthetic medicine has changed dramatically over the last few years. Patients don't just want volume anymore, they want healthier skin, better tissue quality, and results that look natural even years later. And honestly, I think that's a good idea because aging is not simply a loss of volume. It's a biological process happening at every level of the skin. I'm Dr. Madiha Khan from Pakistan, and today I'd like to discuss how regenerative aesthetics is shifting our focus from simply filling the faces to actually improving the tissue behavior. I declare no financial or commercial conflicts of interest, and all treatments and protocols and clinical outcomes presented today are based on my clinical practice and patient experience. For years, we approached aging almost mechanically. We see a hollow and we fill the hollow. But biologically, the process is much more complex. Fibroblasts slow down, collagen degrades, vascularity decreases, oxidative stress increases, and chronic low-grade inflammation or inflammaging gradually changes the skin environment. And that's why some patients don't necessarily look old, but they stop looking fresh. And one of my favorite concepts is skin aging is biological before it becomes visible. We are now witnessing a major shift in aesthetics. Traditional treatments focused mainly on replacing lost volume. Regenerative aesthetic focuses on restoring the cellular function, improving extracellular matrix quality, and stimulating the long-term remodeling. Patients today don't walk into clinics asking to look for dramatically different appearance. Most of them simply say, "Doctor, I just want to look healthier, less tired, more like myself." And that's exactly where bioremodeling fits beautifully. So what is exactly bioremodeling? In simple terms, it's controlled stimulation of the skin's own regenerative pathways. Instead of forcing correction externally, we encourage the tissue itself to repair, regenerate, and reorganize. The key targets are fibroblasts, collagen synthesis, extracellular matrix restoration, angiogenesis, and hydration balance, which means we are not only treating the structure anymore, we are treating the tissue quality. This slide is probably the most important scientific foundation of the talk. Fibroblast senescence reduces the collagen production. The extracellular matrix fragment and weakens. Oxidative stress drives the inflammatory mediators. Reduced angiogenesis compromises the nutrient delivery. And glycation reduces elasticity and tissue resilience. So clinically, we start seeing dullness, laxity, crepiness, and poor skin recovery, which means successful rejuvenation must work at the cellular level, not only the volumetric level. One thing I always explain to the patients is that regeneration takes time. We live in an era of instant gratification, but collagen biology simply doesn't work overnight. Initially, we see the inflammatory signaling, then early type 3 collagen deposition, and over months, remodeling into mature collagen type 1. That's why regenerative treatments often continue improving long after the procedure itself. And honestly, the gradual improvement usually looks far more natural than the aggressive correction. The PDRN, one of my favorite regenerative tools, because it works very elegantly at the cellular level. Through A2A receptor activation, it promotes fibroblast activity, angiogenesis, DNA repair, and dermal recovery. Clinically, patients notice better hydration, improved elasticity, faster healing, and healthier skin quality overall. I often describe PDRN as creating a better biological environment for collagen remodeling. Exosomes. They are fascinating because they completely changed how we think about cellular communication. They don't replace cells, they instruct them through growth factors, cytokines, peptides, and signaling molecules. They influence healing, ECM remodeling, oxidative stress reduction, tissue repair. And I think exosomes represent one of the most exciting frontiers in regenerative aesthetics. Skin boosters, sometimes underestimated because they're subtle, but subtle doesn't mean ineffective. They improve hydration, dermal density, ECM support, and overall skin quality. In younger patients especially, prevention-focused rejuvenation is becoming extremely important. And many young patients today, they aren't waiting to age badly before seeking the treatment. They want healthier aging trajectories. PLLA, the talk of the town. Biofillers. So what makes biofiller interesting is that they combine regeneration with soft volumization. The fibrin scaffold allows gradual growth factor release, fibroblast stimulation, and neocollagenesis while integrating naturally into the tissue. And unlike heavily volumizing approaches, biofillers tend to preserve facial softness and natural movements beautifully. Now PLLA, the talk of the town, one of the strongest examples of biostimulation at depth. Rather than acting as a traditional filler, it creates a controlled inflammatory response that recruits fibroblasts and stimulates long-term type 1 collagen production. And this is important. PLLA improves the tissue behavior, not just the contour. That's why over time we see thicker, firmer, healthier tissue rather than simply more volume. So this is the treatment algorithm that I follow. No single injectable can address every layer of aging. And honestly, I think one of the biggest mistakes in modern aesthetics is expecting just one product to solve everything. Crepey skin behaves differently from volume loss. Texture issues differ from dehydration. Early aging differs from advanced structural aging. That's why combining modalities strategically often produces far superior and more natural outcomes. My personal approach is always individualized. First, assess the skin quality, laxity, hydration, and the volume loss. Second, select the regenerative modality according to the dominant concern that the patient is presenting with. And lastly, layer the treatments gradually over time rather than aggressively correcting everything at once, because tissue integration is usually better when regeneration is respected biologically. Now the outcomes. Over time, patients noticed improved texture, elasticity, better dermal density, and all of this with natural rejuvenation. If you look at the patient here, what I particularly want you to notice is not just improvement in the volume, but reflectivity, skin quality, texture, and tissue vitality. Here in this particular patient, she had ice pick scars. So along with this agents, regenerative tools that I mentioned, I used TCA Cross also. Another patient, volume replacement, but the patient still looking a better version of herself, fresher, healthier, better rested. In her, I used 3 sessions of PLLA because there was a lot of volume loss. I did subcision, I did skin boosters, and over a year later, her appearance improved remarkably. Again, improvement in scars, volume correction, PLLA, biofillers. So all of this results in better reflection of light and a fresher version of himself. And honestly, I think that naturality is becoming the new luxury in town. This was a very interesting case. 38-year-old woman, known case of insulin resistance, hypothyroidism. Along with the lifestyle changes and managing her underlying diseases, we focused on biorevitalization of her skin. And for this, I used glutathione, tranexamic acid, I did biofillers, and 3 sessions of chemoexfoliation. And a year later, her face was rejuvenated, the pigmentation lifted, and she looked a more confident and better version of herself. The same patient. So I truly believe that the future of aesthetics is moving towards biological intelligence. Exosome protocols, AI-guided skin analysis, ECM-targeted therapies, and personalized regenerative medicines are already changing how we approach aging. And perhaps the future aesthetic patient won't be asking us, what filler should I get? Instead, they might ask, how can I improve my skin biology? So to conclude, regenerative aesthetics is not just about abandoning the traditional injectables, it's about using them more intelligently. Thank you so much, and you can ask any questions if you have.
We'll have the questions.
We will take the questions at the end. You can.
For the next speaker, she will be talking about a multimodal approach to hand rejuvenation. Kindly welcome Dr. Guadacadis. She will be talking in behalf of Dr. Vicky Bello.
Which one is it? Good afternoon, everyone. I'm Dr. Guada Santos Capis. It's such an honor to be here, and I'll be presenting in behalf of Dr. Victoria Bello, the chairman of Bello Medical Group Philippines. How do Can I make this bigger? Excuse me, can I make this bigger, please? Can you make it a full page, please? Can you make it bigger? Like a full page? Oh. Our study is a multimodal approach to hand rejuvenation by integrating microcoring cold fiber laser, rose-derived exosomes, and stabilized hybrid cooperative complex HA. We have no disclosures. Hand aging is characterized by thin, fragile skin with dermal thinning, reduced elasticity, textural changes, and increased visibility of the underlying structure. Hand aging is highly prevalent and increases with age. In fact, it affects 90% of women over 50 years old, and over 60% of Asian women report concern about hand appearance. Hands are among the first areas to reveal age. There is therefore a growing demand for effective, safe, and comprehensive rejuvenation solution. Our multimodal approach consists of microcoring cold fiber laser. It creates precise microchannels and controlled thermal stimulation to remodel collagen. We coupled it with rose-derived exosomes, which delivers bioactive signals that reduce inflammation. And the last is the stabilized hybrid cooperative complex HA, which provides deep hydration. Our objective is to evaluate the effectiveness and safety of a multimodal approach combining the three. For our methodology, it's a prospective observational study which we enrolled 15 patients. Each underwent 2 sessions, 1 month apart, of treatments which included microcoring cold fiber laser at 1 millimeter in depth, application of rose-derived exosomes, and injection of stabilized hybrid cooperative complex HA, 1 cc per hand using the 5 injection points. For our results, 100% completed the study with no serious side effects. Hand Aesthetic Improvement Scale showed 87% of patients have at least one grade of improvement. 65% improved 2 grades, and mean increase from baseline of 38%. Skin quality scores improved by 32% in firmness, 28% in elasticity, 30% in smoothness. Patient satisfaction is high at 93%. So these are our before and after photos, which showed improvement in texture, color, tone, and elasticity. For our interpretation of results, there is meaningful clinical improvement because of the high rates of HAIS. There's enhanced skin quality with significant gains in firmness, elasticity, and smoothness. There is high patient satisfaction, and there's good safety profile. So our conclusion, our final takeaway, in 15% of patients, the multimodal protocol combining microcoring cold fiber laser, rose-derived exosomes, and stabilized hybrid cooperative complex HA showed favorable safety profile and measurable improvement in hand skin quality. Gains in elasticity, hydration, luminosity, dermal density, and physician-graded score support the synergistic effects of this approach. We therefore suggest that larger controlled studies are warranted to confirm and expand these findings. That's all for today. Thank you for your kind attention.
Thank you very much. We will take the questions at the end. You kept it short and sweet. So let's now invite Dr. Bruce Reith to talk on pain management in mesotherapy, a prospective randomized control trial comparing ring block, syringe, mesogun, and topical anesthetic cream.
Definitely.
Okay. Where's forward? Okay. Good afternoon and welcome everybody in this last lecture in this session. My name is Dr. Bruce Reith. I'm a Harris-Wilson surgeon based in Munich, Germany. I'm also a fellow of the International Society of Hair Restoration. There's only 100 or 150 in the world. And I'm also a certified mesotherapist, performing mesotherapies since over 15 years. I have no disclosure, no financial relationships or conflicts of interest relevant to this presentation. If we look at the distribution in the market for hair loss, international, especially in the States, hair transplantation medications are a bigger part of it. A growing part is biologics like PRP, stem cells, and exosomes, etc. That's now. In the future, biologics therapies will become a much larger part of our practice. Other will continue to be important with the same number, but the total number of treatments using biologics will increase dramatically. And therefore, also intralesional treatments with mesotherapy like PRP, dutasteride, biglutamide, stem cells, exosomes, biostimulators, etc. That is one reason we should embed it in our practice. You must know that hair loss, it's not an overnight phenomenon. You don't go with a full hair in bed and next day you wake up with a bald, so in the morning. It's a process of miniaturization, which means at the beginning you have very thick and healthy hairs, and under the influence of DHT. The hairs go smaller and smaller and thinner, and then they produce vellus hairs with no pigments. And then it comes to a follicular dropout. No hairs are growing back, and it's replaced by fibrotic tissue. When the hair is the strongest, you have life cycles from 4 to 5 years. The big question is it reversible? Yes, but under some conditions, so you can't get something from nothing. There's a thing called 50% rule, which means if you are able to get the hair follicle at a sort of 50% of its origin, diameter or greater, then in the presence of things like finasteride, PRP, or other treatment, you may be able to bring it back to its original density. You may be able to. Histologically, when primary follicles lose attachment of the erector pili muscle, the hair loss becomes irreversible. Macroscopically, is, as I showed you before, when the hair shaft is less than 50% of its origin diameter or smaller, the arbitrary figure seems to be 50%, which is about 50 microns. If you start medical therapy in this phase, then there's a chance that you can turn back the hands of time. If you are too late, the best thing you can hope for it's trying to maintain the status quo to stop the progression. Therefore, it's very important to know that effective therapies for androgenetic alopecia only work if they are still intact hair follicles. Therefore, early diagnosis and the initiation of HA treatment, like interlesional mesotherapy with PRP or dutasteride, is very important for its success. Treatments are often combined for maximal benefit while keeping potential adverse effects to a minimum. Both treatments work the best if you combine them, if they work in a different pathway like finasteride or PRP. When you combine the therapies, you are not doing the same thing. You use one pathway and you add some other thing and you go to another pathway. So you get synergies and an additive effect because you are doing it in two different ways. On the other side, you are able to lower the side effects. Current HA treatments options include oral anti-androgen, drugs like finasteride or dutasteride. I would prefer dutasteride because it's more effective than finasteride because it inhibits both type 1 and 2 enzymes, whereas finasteride only inhibits type 2. Both drugs have similar rates of sexual dysfunction side effects. Also take topical drugs like minoxidil to improve local microcirculation. Long-term oral drugs doesn't work forever and doesn't work equally for everyone. They can also cause side effects, even if they are only suggestive, and therefore not an option for many patients. And they often have low compliance with the topical drugs. As a result, they frequently seek alternative therapies like mesotherapy with an emerging technique for HA treatment, showed promising results in multiple studies and has the potential to eliminate or reduce systemic side effects of oral treatments. But pain is the most common side effect. That's why local anesthesia with a ring block is used very often to reduce pain. The objective of the study is the aim of this half-head side study sets out to establish whether the use of a mesogun device reduces pain and discomfort that accompany mesotherapy drug administration while potentially eliminates the need for local anesthesia. The study was designed as a prospective randomized controlled split phase scalp trial including 32 patients, 60 male, 50 male, and 1 diverse. A topical anesthetic cream was applied on one facial side and a placebo cream on the contralateral side. Allocation randomized and patient blinded. Both sides were injected with a syringe and mesogun across 1, 2, 3 regions. Pain was assessed from patient and the physicians independently with a self-designed verbal numerical rating scale from 1 to no pain to 10 worst pain ever. Patient received a ring block either before with a hair transplant or 4 weeks later after the first treatment. Study instruments, there were 4 options: a ring block with 2% lidocaine, 5 milliliter syringe with Luolog, a topical anesthetic cream with lidocaine base, tetracaine base, and 4th mesotherapy with Mesogan. The questionnaire was self-designed, numerical and verbal pain scale 1 to 10 with 4 categories: none, mild, moderate, and severe. There were up to 3 regions which were treated: receding hairline, crown, and lower eyelid cheek area, and each scored left and right. After treatment, patient rated their pain on the verbal scale, and the physician refines the score using behavioral cues like facial expression or body movements. The needle size was 31 gauge because the smaller, the less pain, and the better for the patient and everybody. Needle length was 4 millimeter because the agent target are the stem cells area in the bulge and the dermapapillary cells at the hair root area. The most effective agents for intralesional androgenetic treatment with the lowest side effects are PRP, dutasteride, and for women, biglutamide. Due to the side effects and poor compliance, many patients turn to alternative therapies like intraletals, and they are often combined for maximal benefit while keeping potential adverse effects to a minimum. But pain is the most common side effects and the main reason your patient's not continuing the treatment, and you know you need several treatments to succeed. PRP is one of the fundamental agents for hair loss. No side effects and very effective. It works best in combination, provided you do it correctly, e.g. in combination with dutasteride or other intralesional administrations like exosomes in the future. Dutasteride is 3 to 4 times more effective than finasteride, and intralesional mesotherapy with dutasteride every 3 months may be as effective as other more intensive treatment protocols. To date, a total of 32 patients have been enrolled in the study. Of these, 16 patients were male, 15 were female, and 1 was classified as diverse, indicating an overall balanced distribution participants. Treatment of the receding hairline region was performed in 29 of 32 patients. The crown region was treated in 10 patients, and the lower perioral region was treated in 22 patients. With regard to the number of treatment areas, 9 of 32 patients received treatment in a single area, 18 patients underwent treatment in 2 areas, and 5 patients received treatment in all 3 areas. 3 of 32 patients received lower eyelid treatment only, whereas 19 of 32 patients underwent simultaneous treatment of both facial and scalp regions for comparative assessment. No patients qualified as low responders, meaning everyone showed at least moderate benefit from either the Mesogan device or the anesthetic kit, or both. This is a positive finding for the study. As you can see on this side, the Mesogan reduces pain nearly 50% compared to syringe, consistent across both cream conditions. Based on the study data, Mesogan consistently outperforms syringe across all conditions, with cream and without cream, resulting in approximately 49% lower pain levels overall. The combination of Mesogan cream delivers the best results, with the lowest average pain score of 1.41, while syringe without cream produces the highest pain at 4.15, making Mesogan with an anesthetic cream the clear clinical recommendation. Device comparison shows that the Mesogan delivers significantly lower pain scores than syringe across all 3 treatment locations, with the greatest advantage at crown, where Mesogan reduces pain by 57% compared to syringe. Gender comparison shows that women benefit significantly more from anesthetic creams than men, especially at the lower eyelid location, with a 42 pain reduction effect compared to only 18% for men. While at receding hairline, the difference is smaller. All treatments effects are highly statistically significant with a medium effect size Cohen's d 0.77. Anesthetic cream reduces pain by 1 point overall, while Mesogan outperforms syringe 1.36 points with cream and 2.6 points without cream. The treatment effectiveness shows that Mesogan plus cream is the most effective treatment with the lowest pain score and effectiveness, followed by Mesogan alone, syringe plus cream, and syringe alone as the baseline. The 5 key findings are as follows. And some other key visual takeaways are that men show nearly twice the Mesogan advantage compared to while women and younger patients show better cream response. And last but not least, the patient's preference indicates that with the Mesogan and anesthetic ring block, it's no longer required. The clinical recommendations are adopt the Mesogan as a device of choice across all treatment sites, apply anesthetic cream routinely before every treatment. The Mesogan delivers its greatest benefit in the crown. Cream is particularly important for lower eyelid treatments in female patients, and the ring block is no longer required. Thank you for your attention.
Thank you very much. That was a really good study. We'll take the questions now. We'll go speaker-wise. So we'll, any questions from the audience for the various speakers that we have had? Then I would like to ask a question to Dr. Madhiya Khan. Bioremodeling, that's the concept for the future. That's sure that we do really need to improve the whole skin and subcutaneous tissue from the bone outwards for effective rejuvenation. And you use multiple modalities to do this. So is there any sequence that you follow when planning treatment for a patient?
Exactly, there is a sequence, and obviously that varies from patient to patient depending on what dominant skin concern they are presenting with. So I basically start with skin regeneration first. Like for instance, if a patient has come with skin crepiness, dehydrated skin, so my first choice would be to go for a skin booster. If there are structural deficiency also, moderate signs of aging, then I'd go for a PLLE. So basically, I start working with the skin rejuvenation, skin integration, and then I go for correcting the structural changes in the skin. Because a healthier skin responds better to dermal fillers and PLLA. So PLLA being the last one, and PDRN, exosomes, biofiller being the first ones.
So in your sequence, you would start with skin,
improving the skin quality first.
And then when does the PDRN come in? And the PLLA is at the end. That's
At
what
the
you're
end.
saying.
So basically, like for instance, if a patient has come to me, as I said, with mild to moderate signs of aging, so the first treatment that I would go for is skin booster.
Yeah.
And maybe I would, for mild volumization, I might use biofiller depending on the patient. And then 4 weeks later, I would go for a PLLA.
And the time span for this plan?
So again, varies from patient to patient. For like the cases that I showed, in some of them, the treatment plan proceeded for about 8 to 9 months, and mostly about 4 weekly sessions we did. And we started with skin booster. We did about 2 to 3 rounds of skin booster, and I alternated it. Like first, I did a skin booster. And in skin boosters, it's like the ingredients are different. Maybe hyaluronic acid, amino acid, sometimes PDR, and there's so many things coming in the market with combinations. So I do that first, and 4 weeks later, if I need to correct some structural changes also, then I go for a PLLA. So always a skin booster first. And that's how I do it.
Yeah, thank you. And thank you for the lecture. My follow-up question is, as plastic surgeons ourselves, we work hand in hand also to dermatologists, aesthetic doctors. But a very common complaint would be the periorbital area. So have you encountered any surgical patient? The concern mostly of surgical patients would be how would you handle the scar if we're pertaining to the periorbital area, which is also a common procedures for aesthetic doctors.
Yeah. So I presented a talk about a day back in AMWC Korea, and it was about periorbital rejuvenation. And I have a lot of patients on whom I have tried to improve the periorbital area. So yeah, there are patients whom we do not approve for non-surgical treatments, and especially people with big fistulas, larger fat prolapse, too much skin laxity, skin redundancy. But then there are patients who are not willing to proceed with the surgical options, and most of them, they like insist that I should proceed with the non-surgical option. So yeah, we do. I do combination approaches over there also, but in that cases, I combine CO2 fractional laser along with the injectables for the periorbital area.
Thank you so much.
Do you use any IV treatments to supplement or laser treatments, or is it just the ones that you
For-
mentioned
In the, one of
in the monthly modal thing?
Oh, okay. So I know in the large part of the world, IV treatments are not preferred, but in my country, there's a big stigma for brighter skin complexions. So glutathione, IV glutathione is and IV vitamin C is too much preferred. So yeah, we do go for IV sessions also. And in Fitzpatrick's type 3 and 4, if somebody's demanding for a lighter and brighter skin complexion, especially patients coming up with pigmentation and melasma, I do recommend but twice monthly sessions of glutathione combined with vitamin C, and we do offer that.
Because I saw in one of your clinical cases, there was a significant lightening in the pre and the post.
Yeah.
So was that only with the PDRNs and
No, no.
PLLs? What was that
So
due to?
we did combine IV glutathione. In fact, most of the patients we are combining IV glutathione. Even oral glutathione is given to most of them over a 6 months period time.
Okay. Yeah, thank you very much. Uh, uh, any questions for our second speaker? Yeah.
Thank you. Thank you. I want to ask the second speaker about the ring block anesthesia. Is it the same with the regular anesthesia? Yes, that's my question.
It's about the hand or the other?
That's the third.
The third.
The third speaker.
okay,
Oh,
you
sorry,
can ask the
sorry.
question to
Oh, sorry. If yes, if it is the same, why you recommend the Mesocan with topical anesthesia? I mean, like the painless effect, of course, is stronger, a lot stronger in the anesthesia block. That's my question for you.
No, there was,
And my question for first speaker, sorry, if you start,
Let's just finish
Okay,
with him,
okay.
then you can ask
okay,
one at a time.
For me, it's not.
yeah.
I know it's normally a ring block. It's not more needed anymore, and it's not very nice for the patient, and also for the physician. And there are also some agents like PRP to stabilize the membrane, so there could not come out so much growth factors. So it's not very good. With the mesogram, there is normally no pain at all. There's some small twinks. Maybe some strong ones, they can stand it all treatment, but everybody would decide, 100% would decide for the mesogun. And
Also-
pain is really the main reason why the patient is not coming back for the treatment, you know. And ring block is also very painful. I do thousands of ring blocks with hair surgery, so I know.
So ring block in your presentation is same with regular anesthesia block.
Yeah, ring block is
Yeah.
normal, but I know a lot of colleagues do it with PRP or dutasteride. And dutasteride is a very good option in the future because you don't have to take oral finasteride, and then you only have to take it every 3 months, and it works similar like oral, you know, and you don't have no side effects at all.
Dr. Reed, that was a lovely presentation that you made. So the comparison is between your mesotherapy gun with cream was better than without cream or only syringes, right? Is there statistical significance in there? Have you been able to prove it statistically that
There's
it's,
significant. I showed it in my slides. There's a significant for 100%. Yeah,
it's
P 0.0, yeah, 1.
yeah.
Yes.
But have you compared it with block like a
Yes.
supraorbital?
Because I do a lot of hair transplants, And maybe in our clinic we do 100 in a month, so I can compare very well. So but with the hair transplant, I can cover the bald areas, but I can't stop the hair loss. So I have to continue the treatment. So, but after 4 weeks, I can make a ring block. But I can compare ring block with Mesokan. I can compare ring block with syringe, with anesthesia cream. So it's very good. And I compared face with scalp, you know, because in the future there are a lot of biostimulators like PDNR. I make also a study about PDNR, and it was painful, very painful. So patients don't want to come back. So with the Mesokan, there's no more pain.
Yeah. What's the ring block that you give? Is it just supraorbital, supratrochlear,
No,
or you
totally.
give complete subcutaneous?
Totally. Like in hair transplant, I do totally.
But that's because if you only want to inject in this area,
Yeah.
then supraorbital, supratrochlear is good enough to numb this part.
Yes.
Block is required if you want to go more posteriorly.
Long ring block, it means the name says ring block. Make a ring.
Because, yeah, I mean, the ring block is definitely going to be more painful.
Yeah, it's more painful.
Painful,
Exactly. But if you have the whole area, what you will do? You have to do a ring block. So I do it every day, twice. So.
Right. You used dutasteride for injection.
Yes.
So how do you dilute it? What's the
0.01.
0.01?
Yeah, only one company in Spain who is doing it. It's very difficult.
So
because,
it's
a big mafia with pharmacy, you know, because they don't want it on the market.
So
but,
it's not a readily available.
It's available. Yeah, you can order it in with Skymedic.
So dutasteride as a mesotherapy
it's
solution is what you
normally you can buy it ready.
Okay.
But normally you have to say, oh, yeah, I have a pharmacist who is mixed this with all the ingredients, so you have to give the pharmacist the ingredients that he mixes it by himself. But you can you order it ready in a vial. It's possible,
So
and it works very well.
So it's
very
available
good.
as a mesotherapy solution.
Yes, yeah, solution. Yes, exactly.
Okay.
Yeah.
So not the dutasteride that.
No, it's a 5 millimeter vial, and you can do 3 treatments with it. It's perfect. It's not so expensive. And I have amazing results, you know.
Okay, so
And dutasteride is really 3-4 times more effective than finasteride. I told you because it blocks the enzyme on in two locations.
and what's the frequency of injections? How often do you have to inject?
Or it depends what you are doing. Dutasteride, I showed you every 3 months. If you do PRP, you start with 1 treatment and then monthly 3, and then every 6 months.
So every 3 months?
It depends because you have a dermatoscope and you see if it's coming worse, and you do another one. But normally you make 3 within 2 months, and then you resume after half a year. But depends on the situation. But you know, PRP is always good for microcirculation. I see it in my transplant, it doesn't grow. I do PRP, and then the hairs are growing, you know, because the microcirculation is better. But you have to do it correctly, because most physicians do it wrong. They use wrong kits, do it totally wrong.
So you do PRP as well and
Yes.
dutasteride injection?
Yeah, because I told you the combination is always better. The big secret is the combination. If you combine different pathways, I also use low laser level therapy. It also works together. But the problem is you have to tailor it to the patient, because on one side you have to pay it. You have to afford it, and the other side, a lot of patients don't want to take oral medications because they are afraid of side effects, especially with finasteride. So 80% don't accept it. They want to take oral, and then so you need the compliance. They have to take every day finasteride, and the other problem is that it don't work forever. And if you stop finasteride or minoxidil, the hairs will falling out again. So interventional therapy is the best, really. It's the future.
Yeah. So it's alternate. Once PRP, then dutasteride?
No, I do both, because the combination is always better than the monotherapy. And PRP is an adjunctive therapy. It's not a monotherapy. Always do different therapies. I also do exosomes too. That also works together. Because and the PRP works better if you do microneedling before with exosomes, and the PRP works better. There are
Any-
studies for it, yeah.
Any more questions to Dr. Reed from the audience? If not, then I think we'll move on to Dr. You had a question, right?
I have my question for the first speaker. What do you think about skin fibrotic after multiple gem of needle skin booster?
Question to you.
What do you think about skin fibrotic inside the skin after skin booster with needle? Because skin booster we do a lot in our practice and we not doing it only once. We do it multiple times for our patient. So there's some saying that it can cause skin fibrotic. What do you think about it? Thank you.
Okay, so the number of cases that I have done, luckily I haven't come across any of such complications resulting in fibrotic nodules if you're there pointing to them. But it's not like we do unlimited sessions. The maximum sessions that I do in a patient is maybe just 3, because I do a combination therapy. So it's not just skin boosters that we keep on doing. I combine it with microneedling. Maybe we do chemoexfoliation, as I said here. We do biofillers. And all of these, so just 3 sessions, 2 or 3 sessions of skin booster, about 4 to 6 weeks apart. And luckily, so far, I haven't seen any fibrotic changes. It results in better hydration. Depends on what product you're choosing. So maybe any complications that you have heard of or come across, you need to check the product and brand.
Thank you. Do we have any questions for our second speaker? I have a question, Dr. Cadiz. Regarding the demographics of your patient, out of the 15 patient, what was the mean age of this patient? Because I am expecting the appearances of the hand would vary depending on the age group. So can you enlighten us regarding the age group? And the second follow-up is that regarding the technique on how you inject the exosomes or the hyaluronic acid, what was your specific technique? Do you do it directly or do you use cannula in delivering the products?
Okay, for the first question, the demographics is 50 years old and above. And how do we do it? We do microcoring first. We use a laser. It's a 1920 cold fiber laser that creates big micro channels, coring channels, and we use the 1 millimeter depth. We used it because we want to prevent post-inflammatory hyperpigmentation. Our machine can go as deep as 6 millimeters, but at 2, we started getting hyperpigmentation. So since we're Filipinos and we have darker skin, so we used 1 millimeter. After the microcoring, we inject the hybrid cooperative complex. So we identified 5 points, 0.2 cc per injection, deep dermal injection. And then after that, because you already have channels from the microcoring, we just apply the exosomes. Of course, we placed anesthesia prior to that.
All done at the same time.
All done on the same day, and then we did 2 sessions, 1 month apart.
Thank you, and congratulations on your excellent results. Any more question?
If I could ask one. So you use 3 modalities, but would each one of them deliver an improvement on its own, which was similar, or you do need to have the 3 to get this kind of improvement?
Multiple modalities are always better, but actually we started with just using microcoring. And then since we have exosomes in the clinic, we started adding exosomes. And then finally, when we had the hybrid cooperative complex, we added it. And it really gave exponential results as compared to monotherapy alone.
Okay, and any study you have done on this to compare individually?
We actually haven't.
No, okay.
Thank you, doctor.
Thank you. Any more questions? Yeah. I think we've had a lovely session here, some good papers, good research, and some lovely discussion. So I'd like to compliment all our speakers for sticking to time and taking all the questions, and the audience for being here. Thank you. A big round of applause. Thanks. Can we have them up here on the stage for a photograph, please?